Alright, gang. Welcome to the video lecture. Going to give this a go here. We're going to talk now about the autocoids and the antihistamines. The autocoids, well, I guess as we start about this, make sure please get in your handouts, have this in front of you as you look at this, because I'll be referring to that, as I expect you should be referring to that. So, talking about some basic things here, primarily the antihistamines, but even before we get into that, of course, we have to have some definitions. And so, that's where that fancy word, the autocoids, comes from. Take two. And that's the Greek word for self-remedies. So what we're talking about here really are compounds or molecules that the body produces that are designed in the body's attempts to heal itself. So when we look at those, you can see there the basic groups that we're talking about. We're talking about histamine. We're talking about the prostaglandins, the thromboxanes, leukotrienes, and the kinins. Now, if you remember back a little bit, when we talk about the NSAIDs and pain control, we talked about the prostaglandins. That those are involved with, they're mediators of inflammation. They're involved in the sensation of pain, which of course is why the NSAIDs work, because they block prostaglandin production. And you may remember that we even talked about the prostaglandins, I think it's specifically prostaglandin E2, that was involved in the destruction of bone and periodontal disease. So we've talked about those quite a bit. Now the thromboxanes, different kind of category there a little bit. They're more, if you think of like thrombocytes, or they're more really involved as part of blood elements, involved in clotting processes. The leukotrienes we've already talked about in the context of asthma drugs. Leukotrienes are produced as a result of inflammation, and so therefore the leukotrienes are mediators of inflammation. They're produced especially in response to irritation. And so when you think of in the control of asthma, we made a big deal of the fact that inflammation was an ongoing part of that disease process, and especially in resolving that. And so the leukotriene inhibitors, both the synthetic variety of it, that is to say, inhibiting the leukotriene synthesis, and also changing their affinity for their receptors, we talked about during the asthma medications, are a way of dealing with moderating the inflammation that's associated with asthma. So that's one of the other compounds that needs to be mentioned in this group. The last one are the kinins. The kinins are polypeptides that are produced. Polypeptides, that is to say, it's like a breakdown of protein products, like little clumps of amino acids. Again, those are involved with the sensations of pain, somewhat inflammation. Not going to really talk about those too much in this course. The main one we are going to talk about is histamine. And so, of course, before we can really understand antihistamines, we have to understand a little bit about histamines. Histamines are naturally occurring. They're produced primarily by mast cells, although you can find histamine in every cell of the body. I mean, basically every mammal cell produces histamine. But the primary agent that we're talking about are mast cells, usually in the intestinal mucosa and the central nervous system. And so when those are a normal part of are normally secreted as part of the normal body processes. But what can happen is certain things can trigger that, most notably allergens, will cause the body to perceive itself as being under attack. And when that occurs, then the body launches into this whole big, long process of trying to fend that off and deal with that. And one of the main things that happens is the mast cells dump the histamine into the system, and these produce some pretty significant reactions. As you can see in your handout under histamine, the first one, you can see that our vasodilation. Again, these tend to cause inflammation. So if you're going to cause inflammation, you got to boost the blood vessels. So the vasodilation. And again, if you think about the repair processes, it allows defense cells and raw materials and the healing cells to get in there, allow the body to repair, rebuild damaged tissue. Increase capillary permeability. Try that again. Basically what it does is it makes the blood vessels leaky. So first we make them bigger, then we essentially make them leaky. Same kind of concept going on here, is so that these defense cells and repair cells can get into the damaged tissue where we want them to go. Bronchoconstriction. Now that one's a little bit unusual. And the best way I think about this is that this is a way of compensating or balancing the beta-2 type agonist response of bronchodilation. In order to maintain a balance, the body needs, two opposite forces to work together. So that's kind of how I help to think of this. I don't know if it's actually true or not, but it's just a helpful kind of a guide for that. So that, when the histamine gets dumped into the system, one of the things that happens is we tend to see some bronchoconstriction, and that's going to become significant in a couple minutes. When we talk about some of the more severe reactions in allergies, which we've already talked about a little bit. We talked about anaphylaxis. The gastric acid secretion, we already talked about that one a little bit when we talked about the H2 receptor antagonists in the gastric mucosa. And of course, when the H2 receptors are stimulated, we get an increase in stomach acid. So that's why we talked about the H2 receptor antagonists or blockers back when we talked about the GI drugs. So of course, those are going to be much more involved in things like ulcers and gastritis and some of those other kind of things. The last pharmacologic effect that we see is it stimulates nerve endings in the skin that kind of causes pain or itching. And of course, the best way to think about all this is, most of us have intuitively know, we've had a personal experience, to know that we take antihistamines in response to things like hay fever. But if you think of, if you've ever had hay fever, or you know somebody's had hay fever, or any kind of really bad allergic reaction, you tend to think of a lot of these sort of respiratory things. You think of, actually one of the best examples, let me back up the bus here, that I bet most everybody's had some experience with, are either poison ivy, or mosquito bites, or sunburn, because all of those are kind of examples. In the case of poison ivy, that's the body responding to the toxins from the plant that sets up what causes the itching, and all those responses are really not the juice of the plant itself, but it's actually the body's response to that. Likewise, in the case of mosquito bites, the same thing. It's the compounds that the mosquito injects in order to tap into the blood supply to cause that little welt that causes that to itch so bad. And again, sunburn is nothing more than when the UV light alters the DNA. It causes literally damage at the DNA level of the cells on the skin, of the epithelium, wherein the body no longer recognizes that as our cells. So what happens is it sets up an attack of that like it's in a foreign invader, and so we get the redness, and sometimes we get blistering, and in more extreme cases, of course, you get the really bad burning, and where it'll just literally peel off or slough off, and that's really because the body is just rejecting that. It's a classic allergenic rejection kind of thing. So when you think of the pain and itching, that's classically what we're talking about. And again, if you've ever had any of those things, you get some of the raising, the welts, and the vasodilation that goes along with that. It's classic. So, okay. The bronchoconstriction, though, is the biggie. When we talk about histamine release in the body, far and away the biggest medical threat is from the bronchoconstriction. The others are annoying. They make you miserable, but they're really not life-threatening. I mean, no one ever died from a mosquito bite kind of thing. It's one of those. But bronchoconstriction in extreme case can be very dangerous because, of course, it can get to a point to where literally the airway swells shut and the person can't breathe. And so obviously, don't breathe long enough, that's kind of incompatible with life. And in response to an allergy, that's what we call the anaphylactic reaction. If you go way back to one of the first lectures, I think the first or second lecture of the course, we talked about different types of allergic reactions. That is one of the biggies, was the anaphylactic, the type 1 reaction. And this is the one that we've got to really worry about, because this one is the worst. This is the full body, full bore. Right now, you just tend to see a lot of changes. Things, as I said, the biggest one being the bronchoconstriction. We also tend to see the blood pressure crashing. I mean, it isn't just lower. I mean, it like bottoms out. So of course, then the person goes into shock. You stop breathing. The heart stops. In that case, we need to reverse the effects now. Even though we're talking about antihistamines, in this case, because it's such an immediate, massive reaction, the proper response is to give epinephrine. We've already mentioned that, and that's because epinephrine works so well at the beta-2 receptors at bronchodilation. It counteracts directly the bronchodilation, and it does it immediately, which of course is extremely important. The other thing, when you think of low blood pressure, when you think of the shock, the stimulation of that beta-1 receptor that we know, okay, well, that's going to raise the heart rate, that's going to tend to increase the blood pressure, so it's going to counteract that. Is a very good thing. So that's why epinephrine is always given in an anaphylactic reaction as the first drug of choice. It doesn't last real long, so of course, as we'll talk more about when we get to the emergency drugs, you have to give it several times. That's not at all uncommon. The other thing is that very commonly, in an emergency situation, you give the epinephrine, then you follow that up immediately with an antihistamine, because that's going to give you a little bit longer response on some of these other kind of measures. It'll help sustain the blood pressure, some of the other things that we talk about. Okay, so long-winded explanation of what histamine does, and sometimes the good, the bad, and the ugly. You'll see under item C in your handout the clinical uses. Here's the bottom line, gang. There are no clinical uses. I mean, yes, technically, you can check and you administer it to see if you get some stomach acid being produced, or it can be used maybe to check for a certain kind of tumor. It's not something that we're going to see. There's a lot of other ways that, frankly, it's being done now. So it really has, we just kind of have to understand histamine in order to understand the antihistamines. Please hear this loud and clear. I am not going to ask you ever in any kind of a context what a medical use or a purpose of histamine is, other than to know what some of its clinical actions are. That's the most important thing I want you to know. Excuse me. Okay, so now that we've talked about the histamines, we can actually get into the antihistamines, because of course that will help us to understand what the antihistamines do. So of course, and when we talk about the antihistamines, what we're really talking about here are the H1 receptors. We're really not talking about blocking the H2 receptor. All the drugs that we're going to be talking about in this section, primarily H1. Yeah, obviously there's H2 receptor blockers, receptor antagonists. We've already talked about those under the GI drugs. But the classic antihistamines that we've talked, that you probably all have personal experience with, primarily H1. So of course it's going to help make the capillaries less permeable, so we're going to get less peripheral inflammation. It's going to tend to keep those blood vessels from dilating so much. It definitely helps with some of the pain and itching at the nerve endings that we tend to see. And what's really interesting is the antihistamines do nothing. Zip. Nada. Not a bit of benefit or clinical activity at the level of bronchoconstriction, which is another reason why we would use epinephrine in an emergency situation, because you can pump somebody with all the antihistamines you want. You're not going to dilate those bronchioles. So obviously that's kind of like job one in that circumstance. Now, that's all well and good. Now there's the other parts that everybody really intuitively knows. Again, this is a pretty easy section because most of you have had enough personal experience. You already pretty well know what these things do. These drugs do tend to depress the central nervous system. So, of course, what does that mean? They're sedatives. And we're going to talk about the prototype drug of the antihistamines is Benadryl, diphenhydramine. Well, yeah, as you all know, that's the big deal with Benadryl is it's very sedating. In fact, it's so sedating, as we talked about way back when I first mentioned the difference between the therapeutic effect and an adverse effect. Normally we think of the sedation as being an adverse effect of the antihistamines, but it's actually in most of the over-the-counter sleep drugs or sleep aids, things like Nitol, things like, I just blanked on the other one, but a lot of the ones when you go in the drugstore that you buy over the counter are typically antihistamines. And the reason for that is we're counting on that sedation, the sedative properties that normally we think of as an adverse reaction, and here it's designed as a therapeutic effect. Not coincidentally, you will find it in a lot of cold medications. And I think one of its main benefits is again, because when you have a cold, it's really not an allergic phenomenon. But that sedation can be kind of nice, because especially if you have a head cold kind of thing, breathing can be difficult, it can be hard to sleep. This is a very good thing to help people get to sleep. Now, having said that, there's a big, huge asterisk we've got to draw there. And that is that for whatever reason, and I'm certainly not going to pretend to know, but I know it happens. Very often in children, especially young children, and the elderly, these drugs will have the opposite reaction than what we expect. So what we often see, where most of us adults, we would take Benadryl, boom, it's lights out. It'd be looking like most of you guys about 8 in the morning on Tuesdays. It's Sleep City. You give it to that population, and very often it just turns them up. They get, it's the opposite of sedation. They're ramped up. They're bouncing off the walls. I had conversations with parents who were, had the sick kid, and they're getting kind of desperate. So they think, well, maybe I'll give them some Benadryl, calm that sedation, knock them out, then we'll all get some sleep. Well, the exact opposite happens, and so now, it's bad enough. It's late at night. Kid's sick, miserable. Parents are just like, at the end of the rope. And now they've got this kid bouncing off the walls, and they're going, oh, now what do we do? So that is a reality. So you got to take that a little bit easy with that. And I guess needless to say, until you're sure, probably not a good idea to give them a 12-hour dose of it. Do one of the standard morning for like 4-hour kind of thing. And of course, these drugs have anticholinergic effects. What's that? I think I was supposed to hear you say dry mouth or xerostomia. I think I heard a little bit of that, but we'll try it again just to make sure. These drugs have anticholinergic effects. Okay, that's better. Hands down, these drugs are going to dry people up. Again, if you think of head cold, sinuses all plugged up, this is a benefit. I think that's why very often you'll find these drugs in there. It has nothing to do with allergies, because it just helps dry people up and helps sedate them. That can be a good thing. But, if it's not that, again, people who take these a lot, this can be an issue for us, especially if they're already taking it with other meds that tend to be anticholinergic. Then you can get some additive effects. Now, having said that, well, actually, we talked a little bit, going on down to item 5, that in the GI drugs, when we talked about the antiemetic drugs, some of the ones we mentioned were these, we talked about Dramamine, we talked about Bonine, talked about Phenergan. These are all antihistamines that have some really good antiemetic effect. They tend to depress the chemoreceptive trigger zone, CTZ, or what I call Puke Central, in the brain, and tend to diminish that nausea and vomiting. So these drugs are often used because they're sedative and they're dry, they dry people up, they're anticholinergic, and they're antiemetic. You often see one of these drugs used as part of a mixture when people do general anesthesia. Because again, you can imagine, well, I think I've already mentioned this in class, that some of the general anesthetic agents tend to cause some nausea after the fact. If you have to intubate somebody, obviously it's beneficial when we're trying to sedate them, so to knock them out and get them already drowsy is a good thing. To dry them up is a good thing if we're running a tube down there. And then if we have this antiemetic effect on board that will mediate any added effect afterwards of nausea and vomiting, that's also good. Especially think about, if you've done some surgery in anywhere like the abdomen or even in head and neck area, having somebody all that lovely muscle activity of vomiting is not a really good thing. So you can often see that. So very classically, we will find these drugs used in that particular realm of medicine as part of what's called a cocktail of general anesthesia. So there's special ones, and I talked about Phenergan being the biggie that's more as a prescription use or more used in medicine. Over the counter, it's a little bit different. Now your text talks about specifically of Benadryl, that because these are chemically related to the local anesthetic agents, that you can use these. You can mix up a solution and inject it in a syringe. And that's probably true. I've never had occasion to use that. And that would be useful in the rare event you have somebody who's allergic to the amide local anesthetics and you just can't get yourself on the ester, or they're allergic to that too. Doesn't happen very often. But I guess that's out there in case you'd ever need it. Adverse reaction. Again, moving on to item B here. Or the antihistamines, we've already pretty well, I think, beat that one to death. But notice it isn't just sleepiness, it causes some other things with that in higher doses. And then the GI effects as well. It's kind of interesting. Okay, anorexia makes you not want to eat. No, it's not a good diet drug. We've already talked about the nausea and vomiting. Now, wait a minute, didn't we just say it could be useful to treat nausea and vomiting? Yeah, it's one of those things. It's like, all right, I didn't quite get that one either. But sometimes you can see those extremes. It's sort of like the benzodiazepines that can either dry you up or cause you to salivate excessively. One of those fun things. And we already talked about the xerostomia. And because it tends to be a CNS depressant, it tends to slow down the peristaltic wave. So we're going to see these drugs being mildly constipating. Okay. I think we pretty well covered those. The difference between the adverse reaction and the therapeutic effect is kind of just depends on what you're looking for. I guess that's the short and sweet of that. So what are these drugs used for? Well, obviously allergic reactions. Pretty much when you think of hay fever, that's the typical over-the-counter use of those. Definitely it can be used in an emergency situation as sort of the secondary drug because of the bronchoconstriction that these antihistamines don't treat, the epinephrine does. Already talked about the nausea and vomiting that can be useful for that. Please understand, we've already mentioned this before, we talked about the antiemetic drugs and the gastrointestinal drugs, I should say. Excuse me. But these drugs are never used during pregnancy. Forget it. Just not an option. So that kind of nausea, it doesn't apply here. So what do we do then? That's when we talked about the two biggies that I've encountered are saltine crackers and ginger. And I guess you certainly could put them together. But that's a biggie that, yeah, these are good antiemetic drugs, but just not pregnancy. Usually it's more motion sickness, as we talked about. Pre-op sedation, same thing. They're used in a cocktail. You can see that. But the over-the-counter sleep aids, Nital Compose, we've already talked about, that those are commonly used. And then understand, too, in addition to just being standalone products, they're often mixed with a lot of cold and flu remedies. You'll see that a lot, that they're these combination products that are put together that are things like, they'll typically have acetaminophen in them. They'll typically have one of the alpha agonists, like phenylephrine, that'll help act as a decanter. Pseudoephedrine is a biggie that'll help dry up the mucosa. You'll often find one of the antihistamines in there. as that process. And then depending what other formulations, you might have a guaifenesin in there to help loosen up any congestion or respiratory things like that. So depending on what formulation you buy. Okay. The biggie here that we'll talk about is Benadryl or diphenhydramine. That's sort of like the big one. And your text has a wonderful table of all of a lot of the over-the-counter ones, actually a lot of the prescription ones too. And it's really nice because it talks about, you can literally see which ones are especially good for as a true antihistamine blocking, which ones are really good or more or less sedating. You can play that game. Like if you want to put someone to sleep, like for your kid, or if it's maybe for you, so maybe you give them the Benadryl if you want them to sleep more, if it works from that way. Or perhaps you're using a chlorpheniramine. Try that again. Chlorpheniramine is a good antihistamine that is not as sedating as Benadryl. For instance, it's available over the counter. Now, because of this sedation issue, there has been a lot of interest in coming up with prescription-based products that are not sedating. And so, you might see references to the early one was trifenadine or Seldane. It's in your notes. That was the first one. There were some drug interactions. It's no longer on the market, so we're not going to mess with that one. But Allegra and Claritin are probably the two biggies that are out there. Bottom line of these drugs that you can see that they are much less sedating than, like, say, Benadryl. Diphenhydramine or Benadryl is sort of the prototype. That's the one we all compare it to. But they also typically are not as good at antihistamine. They don't block histamines as well as Benadryl. I will tell you that, when you really look, Benadryl is about as good as it gets, but it comes with a price, and that's why we have issues with it. When you look at Claritin versus Allegra, or loratadine versus fexofenadine, bottom line is Allegra doesn't last as long as Claritin, but has less xerostomia. So you kind of play this game of trading this off. Claritin comes in 12 and 24-hour forms, and so that's kind of nice, I guess, for hay fever. You don't have to take the drug as often. But and in combination with that, well, you see Hismanol there. I put that down there more for historic purposes. Again, that was a drug that's been taken off the market. A newer one that's out there is Cetirizine or Zyrtec. Of course, you can see their ads too. Everybody seems to have they run in cycles of putting their ads on TV. Basically, as we compare Zyrtec with Claritin, certainly not as long-lasting. So you got to dose it a little bit more frequently. But again, the take-home message of all of these drugs are that they do work pretty well, much less sedating, but not, you get good histamine blocking, but not quite on par with Benadryl. But for many folks, it's better to have a little bit less histamine blocking and still be able to do things like drive and work and stuff like that. So I will just tell you, as an employer, I don't really think it's a good thing when my employees are sleeping on the job, especially if they tend to be dental hygienists with very sharp instruments in people's mouths. That doesn't go over real well. It's a kind of an OSHA dental board patient care thing, not really a practice builder. So, okay. So let's go back. We'll finish up. You can see at the bottom page just a little handful of things about the autocoids. Prostaglandins we've already talked about. Leukotrienes. Again, there's a lot of talk. I have that in there about the kinins as something that's being going on. A lot of research. Everybody wants to come up with the next great thing. I'm not aware of anything on the horizon from a drug perspective, but it wouldn't surprise me where somewhere in our practice lifetimes that there will be some drug that would involve itself with blocking kinin production, and that would be a useful drug to control both inflammation and pain. We've already talked about way back when that the NSAIDs prevent the prostaglandin synthesis, which is we already mentioned. That's why they work so well for pain and inflammation. There's really not much else to talk about. So hopefully that will take care of the autocoids and the antihistamines. And of course, if you have any questions, you can ask me in person or shoot me an email. Thanks.